Yeah.
Very good. Riley, let me know when you guys are ready um, to launch the.
Sure. Are we ready to make the webinar live now?
I think so. It's almost 3. So
Okay, sure. Let me just take a picture of everybody.
yeah, good picture.
Okay. All right.
And
I'm going to make the webinar live now.
Thank you, Riley. Thank you.
Thank you.
very good. Well, welcome to Progenesis webinar session number 24. Today's topic is progesterone as a physiological trigger for ovulation, the new paradigm in luteal phase support. And we're very lucky to have a great panel of experts. We have with us Dr. Dozortsev. He is the scientific director of the Advanced Fertility Center of Texas, also president of the American College of Embryology. We have Dr. Trolice. He's professor of obstetrics and gynecology at the University of Central Florida, also director of the fertility care, the IVF Center. And we have Dr. Albertini, editor-in-chief of the Journal of Assisted Reproduction and Genetics and professor of reproductive cell biology at Bedford Research Foundation. We have Dr. Diamond. He's senior vice president of research in reproductive endocrinology at Augusta University. Thank you so much for joining us.
Thank you.
Well,
yeah.
Thank you for inviting us.
Fantastic. So what triggers this webinar is really a publication that was very interesting, kind of changed the way I have seen the role of progesterone. I wanted to bring that as a starting point. I have 2 co-authors of that paper. Maybe you can, Riley, you can post the paper on the screen. And what I would like to ask both you, Dimitri and Michael, is give us your thoughts on this paper and what the paper brings as far as the new paradigm. And I'll start with you, Dimitri.
Okay. It has been known for a while that progesterone can trigger LH surge in human females. However, it was never really recognized as a physiological trigger of ovulation because, LH surge, because there were 2 major blocks preventing progesterone from becoming known as a physiological trigger of ovulation. One of them was that progesterone historically is known as a hormone which blocks ovulation during the pregnancy, and that's how it was originally finding his way into birth control pills, which are used to block ovulation. So this was one property of progesterone which had to be resolved, reconciled, I should say, with its ability to become a physiological trigger of ovulation. And second, probably even more serious obstacle to accept it as a physiological trigger were experiments, very good experiments, Leitenbecker done more than 30 years ago, which showed that you can induce LH surge with estrogens injection in a woman which has no ovaries at all, and so there is no progesterone, obviously, that can be derived from this ovary because she simply doesn't have ovaries. So those were 2 major obstacles in the way of evidences which we did have of progesterone being able to elicit LH surge. And so in this publication, this was, there actually were 2 publications. This was InkLink, which is on the screen now, and then we had a large reviewed as well, where we reconciled progesterone ability to induce LH surge with its ability to block LH surge during birth control regimens, and also explained why Littenberg was able to elicit LH surge in a woman with estrogens alone, which did not have any endogenic progesterone in the ovaries. So this was, I guess, the main subject of the publication.
Thank you so much. Riley, I think you were displaying the other paper. I just sent you a link for the correct paper, if you can post it for a second. And then we're gonna take Michael on this same introduction of these concepts.
Sure. So I think Dimitri has given a very good overview of some of the reasons for our interest in this topic. I will just try to add a couple comments, which hopefully will be complementary in nature. When I was going through my training in medical school and residency and as a reproductive endocrine fellow, and as we started in the early days of IVF and ovulation induction with gonadotrophins, the paradigm upon which all of our teaching was based, and even our thoughts about the regimens for ovulation induction and actually inducing ovulation, were all at that time based on the thought and the paradigm that estradiol was the key factor in leading to a mid-cycle LH surge and then leading to ovulation. Some of the things that we identified, though, and IVF and assisted reproductive technologies have been great because they've helped many couples who otherwise would not have been able to conceive to be able to do so. But the other thing that the use of these agents and our experiences from these cycles have taught us is they've taught us a lot about physiology and pathophysiology, which in this case goes back to one of the early questions. We know that with superovulation, that individuals will often achieve estradiol levels very early in their cycle, exceeding the threshold that we thought was important for inducing the LH surge, but it didn't happen. Although I don't know that we fully recognize the implications of that, nonetheless, as we look back, we can see that that should have triggered a question. If estradiol was so important, why were these women who were getting estradiol levels to 600 and 900 picograms per mil and even higher, why were they not ovulating? And what this manuscript attempts to do is to provide a hypothesis and an explanation for that observation and some other clinical observations that we could discuss today as well, that it may not be estradiol that is the key factor that is responsible for inducing the LH surge. Estradiol may go along, but what we're proposing as a hypothesis, which we hope will be a nidus for future testing and assessment, is that in fact it is progesterone, which is the key hormone, which is responsible for inducing the LH surge and then leading to ovulation. And if this in fact is correct, this actually will have then implications for ovulation induction, for what might be needed to achieve ovulation. Are you going to need to give HCG or other agents with the potential for increased risk of ovarian hyperstimulation syndrome? And what would happen with hormonal and growth factor dynamics throughout the luteal phase, also in association with a more physiologic factor, the rise in progesterone leading to the LH surge and subsequently to ovulation.
Thank you so much. David, what do you make out of this? Knowing progesterone typically used to block ovulation and now proposed as a way to induce ovulation in a very specific window. What is your perspective?
Well, I think my initial take on the hypothesis was this makes perfect sense from an evolutionary point of view. Long before we had a hypothalamus working with the pituitary, the core inducers for ovulation in most animals was known to be a steroid product from the ovary that elicited the resumption of meiosis and ovulation for those species, spawning species, for example. And in fact, this paper prompted me to go back and ask, when was the first demonstration that progesterone induced ovulation? And I found a 1937 paper in Nature that showed this to be the case in the frog. Now, that said, evolution has brought reproductive physiology a long way from the very primitive forms of a reproductive axis used by invertebrates and later on vertebrates. And I do think the point is very well taken, as Michael had said, that we were taught a certain paradigm for menstrual cycle regulation and ovulation. And that has certainly not only placed the emphasis on LH as an ovulation-inducing stimulus, but the importance of FSH as well. So my initial reaction was, this is really interesting because it may be uncovering a very primitive form of regulation, and as the paper states, an LH independent mechanism for bringing about ovulation. And quite honestly, they propose a really interesting series of interactions in terms of invoking kisspeptin and other things we know about the GnRH neurons that will make the way these steroid products of the ovary feed back on the hypothalamus and pituitary. It'll give us a very new viewpoint for trying to understand that. So that was my initial reaction, okay? I have other reactions that we can turn to at some point, but I don't want to dominate the conversation quite yet. It does generally have to do with, we use COS kind of historically to stimulate the ovary as much as possible to get as many eggs as possible. And I think it's very hard to rationalize our sort of greedy, more is better hypothesis with not only conventional stim protocols and the fact that we're moving away from things like HCG, down the road, when you look at how many of the oocytes we retrieve make a baby, it's very small. We can make lots of embryos, lots of blastocysts. We can biopsy them, you can freeze them, you can transfer them, you can do single embryo transfers. But none of these so-called advances of the last few years have really made a big difference in terms of the link between a quality oocyte and a term pregnancy. I'll leave it at that for now and look forward to more discussion.
Very good. Mark?
Yeah, thank you, Nabil. And I just want to let you all know I'm honored to be a part of this panel with such esteemed guests. So thank you for including me to participate. I think it's a very exciting concept. Dr. Diamond and Dr. Dozortsev have come up with a novel approach. And we're scratching the surface, I think, with what we are learning about progesterone. Back in 2015, a paper from China looked at medroxyprogesterone acetate as an inhibitor of the LH surge during stimulation that could potentially then rid the agonist and the antagonist. I look at this and I say that I don't think the paper really was eliminating any particular factor. I think it's still room for estradiol peak stimulating the progesterone that can stimulate the LH surge. The argument, if I could somewhat be devil's advocate respectfully with the brilliant minds that are here, the argument about peaking estradiol levels during gonadotropin stimulation not resulting in ovulation. When I trained, and that's when you know you're getting old, when you say when I trained, I remember that when they were not using the GnRH agonist, and about a third of the cycles did prematurely ovulate. The reason that the rest of them didn't was because of gonadotropin surge inhibitory factor. That was the plausible theory there. But about a third of them did ovulate. So I don't know if we could negate or at least use that argument to specifically say that estradiol, supraphysiologic levels of estradiol are not going to induce ovulation. Paradoxically, the argument was made about progesterone rising during controlled ovarian hyperstimulation not resulting in ovulation, which didn't make complete sense to me because elevations in progesterone then was part of this argument that it would induce ovulation. So why would premature luteinization, as it were, not result in ovulation? So these are some questions. I found it fascinating. A group that I actually used to be part of in Charlotte, Brad Hurst and others, looked at low levels of estradiol with letrozole, and it did, with those low levels, the letrozole cycles didn't result in obviously ovulation, but it does result in endometrial proliferation. Why is that the case? Why can letrozole be so low throughout the follicular phase, and patients can still ovulate, right? Even though estradiol levels are very low. So you say, well, it's not the estradiol, but endometrial proliferation is completely adequate. So is it that there is another factor involved? Is it that we're underestimating estradiol's levels that have an effect? Now, granted, over time, given enough time, even low doses of estradiol are going to result in proliferation, but these patients are stimulating in over a week or so, and they're getting good estradiol, good endometrial proliferation. So, as I say, I don't think that we can exclude estradiol from an important role in this factor. The only question that I had, and I would love to hear what Dr. Diamond and Dr. Dozortsev have to say, was what do you think the theoretical purpose of the proposed double LH surge that you all hypothesized about, of why they would get that? I mean, what teleologic purpose would that serve, do you think?
I think you're muted.
Michael, do you want to answer this question or you want me to answer it?
I think both. I mean,
Both?
anyone. Yeah, both. Yeah, so we can hear both perspectives.
So who is going first?
You're gonna.
Tell us.
Go ahead.
I go first, okay. I will not answer comprehensively, Mark, to the question, but I will try my best. In cases where we use antagonist, estradiol can go as high as it wants, and progesterone can go as high as it wants. There will be no LH surge because we disengage GnRH pathway downstream.
Right.
So this is why, even with very high progesterone, we will not have any effect on follicles. And even if, for example, one of the large follicles would pop, and as a result, progesterone would go very high, there will be no LH storage because we block this chain downstream. Now, the more interesting question, which I want to answer, is about progesterone and estradiol. Like what, just maybe a little bit elaborate on our idea how it works. If you look at different species, then you will see that in sheep, unlike humans, progesterone doesn't do anything. You know, they will ovulate with estradiol. As estradiol begins to go down. And what we believe happens, we believe that evolutionary, the nature created like a foolproof system so that when follicle, and this is a very important point, which actually David brings up often in his talk, of a link between the physiology of the follicle and overriding higher level of endocrine regulation of this process. They have to work together. They have to work together. And so what happens, follicle has to have a feedback reporting about its state to the hypothalamus. And when follicle begins to deteriorate, which will happen even without any hormones, it will just happen because it's growing. And at some point, the cortical tissue can no longer accommodate the expansion, and it will rupture. It will rupture. So what happens? The hypothalamus must be informed about impending rupture, because if it's not, then the coordination between the rupture and the resumption of meiosis and the starting of proliferation of endometrium will not happen. So once estradiol begins to drop, and it will begin to drop as follicle begins to lose its integrity, LH will begin to become released. And or if progesterone first reaches the triggering level, which based on what we could find is about 0.5 nanograms per ml in circulation, and based on our experience, not more than 1 nanogram per ml in circulation, it will trigger GnRH pathway. So, and what happens if estradiol begins to drop first below the threshold level, after it reaches the peak, then LH will be released because of the drop in estradiol. As LH is released, you will have luteinization in the follicle, progesterone will go up if it wasn't high already, and then it will trigger GnRH pathway. So this way, it becomes a foolproof system which will trigger LH, if not by dropping estradiol, then by going up progesterone. And in some animals, like sheep, it seems like estradiol is dropped from the highest level, is responsible for triggering LH, because what happens, LH accumulates, right, in the granules, and so accumulates because estradiol is going up. And when estradiol goes down, after the peak even a little bit, this accumulated granules of LH will migrate toward the periphery of the cells and will be released. And if it doesn't happen, then progesterone will trigger GnRH and will induce LH release. And so in some animals, we see that one pathway prevails. In others, like humans or mice, it will be primarily progesterone. And in humans, it seems like, because a considerable percentage of patients have not patients, women, have 2 LH peaks, we think that both our mechanisms are working in about equal proportion. This would be my answer.
Thank you so much. Michael?
Well, as I understood Mark's question, it was more teleologically, why would you have it? And I think the answer I would give, obviously I don't know for sure, but the answer I would give is within what Dmitri's much more comprehensive answer, and that it represents a fail-safe. So if one approach, one mechanism doesn't lead to ovulation, then hopefully the other will, in order to allow perpetuation of the species.
Very good. David, you were going to talk about your other, piece of opinion, and I wanted to get you started on that. Tell us what you think now on the other side. What's your thoughts about the whole concept?
Yeah, no, I thought it was interesting how, Dmitry and Michael kind of wove the property of luteinization in the granulosa cells into this argument. If I understood them correctly, there is a history that they alluded to, which has told us that, in fact, granulosa cells are programmed to spontaneously differentiate. And this has been known since the days of Cornelia Channing when I was a student, okay? The fact that in the complete absence of LH, these cells express a spontaneous ability to luteinize. And if I understand your model correctly, is it maybe some degree of what we would call premature luteinization that is part of this feedback signal? I mean, you're suggesting that it's not simply the dip in E2, okay, but that there is a propensity for these cells, unless appropriately suppressed, to go that route anyway. I mean, long before ovulation. What makes this an interesting model, if we can only get a handle on it, is the last 20 years have helped us understand, at least in mammalian models, what the nature of the inhibitor is. Alex Safiri and Channing and them postulated that there was an inhibitor in follicular fluid years and years ago. And, I was fortunate 20 years ago to begin to work with people like Marty Matzik, where, factors like GDF9 and BMP15 emerged in the mouse knockout experiments as, in fact, these suppressors of luteinization. So my first question is, am I reading you right in terms of, some degree of what we would call premature luteinization is actually a good sign that we're maybe setting off this positive feedback limb, number one. And number two, what's the impact of COS as we use it today on this? Okay, your model is attempting to sort of impose, a new way of thinking about the normal feedback control in a cycle. But one of the things that we showed years ago is that, yeah, FSH is wonderful for granulosa cells to stimulate growth, proliferation, induction of aromatase, induction of LH receptors, but it is counteractive to the quality of the egg. And the reason for that, which was shown years ago, is it starts to make the cumulus cells luteinize. And when a cumulus cell luteinizes, it has a direct effect on meiotic status on the oocyte. There were some interesting papers I was planning to send you guys after we have this conversation about this. But that's kind of where I'm at in terms of taking it a little bit out of the axis and into the follicle, because I think there are some interesting implications locally.
Yes. Can I go ahead and answer?
Of course.
Okay, so yeah, absolutely. We believe that this spontaneous luteinization takes place before LH. It's possible. It's one of the possibilities. But we look at this luteinization in a very narrow sense, because the only way we can estimate this luteinization is by seeing progesterone going up. And there may be a different reason for progesterone going up before LH surge, which is because of changes of a milieu within the follicle. There is another mechanism which doesn't involve luteinization. It's simply the constitutive production of progesterone may go up a little bit, which will be sufficient for triggering LH. So it can be one of those two possibilities. We are kind of reluctant to say it's a premature luteinization just because then the whole sequence falls apart. Like you have luteinization before LH, right? So it's kind of, it's strange. It's possible. It's one of the possibilities. And about FSH, about FSH and stimulation, I want to kind of go into that. Our vision of a relation between a FSH, amount of FSH, you can say, and quality of eggs is a little bit different than what I guess most people think as an amount of FSH, which is detrimental for egg quality. I personally believe that FSH has very little impact by itself, a direct impact on egg quality. I think what rather happens, because with more FSH, the follicles will tend to grow faster. And we know there are a couple of very well done studies which show that during the ovarian stimulation, the follicles are growing about 1.2 times quicker, faster than during the regular follicular phase. And the more FSH you give, you basically, you're pumping more fluid into the follicle. You make it grow quicker. But the next kind of extension we make is we're comparing the growth of the egg within the follicle to the growth of the fetus inside of the woman's belly. There is no relationship between the amount of water or size of the belly and the quality of the fetus. It would be very silly for an OBGYN to measure the woman's belly and try to predict when she will deliver a term baby. This would be very strange. But it's exactly what we are doing with IVF. We measure the follicle and try to predict whether the egg is mature, metabolically competent. And so what we see, the relationship between FSH and quality of the egg is really indirect impact of FSH amount, so eggs would grow quicker, follicles would grow quicker, so we're compelled to take them out quicker, and we don't give them enough time of the follicle, because it's interesting, there was an article in Nature just recently published where it turns out that follicular phase in an average female is 14.9 days. 14.9 days, okay? And this is before LH surge. So from the last day of the period to the LH surge, it's 14, not to ovulation, which is important, but to LH surge, 14 days, 14.9 days. And the average follicular phase in the control stimulation is only maybe 11. And so if you extrapolate the duration of the follicular phase with the duration of the pregnancy, 10 days would be about 28, 29 weeks. Granted, this is a very crude comparison. But if nature wants an egg to be in a growing phase, in the follicular phase for almost 15 days, maybe this is where the problem is. We just don't give it enough time to acquire competence. And this would be my bigger concern than the amount of FSH.
Yeah, I think it's, if I can just, add one comment to what Dmitry said. And I should mention that someone just asked a question about the sheep model and specifically the Barola sheep. There are strains of sheep, that are super fecund. They ovulate 12, 15, 16 eggs at a time. And the lesson from that work, some of which started with Ken McNatty, is that a competent egg really just requires the input of granulosa cells from a preantral follicle. The job is done before it turns into a functional endocrine organ. Okay? So in principle, what we do in COS is, as you say, accumulate fluid, more cells, more estrogen in these containers, okay, while the oocyte essentially has to wait around to
Yes,
perform,
yes,
okay?
yes.
And while it's waiting around to perform, depending on what kind of a responder you're dealing with and how much FSH you have to apply, et cetera, that oocyte is losing quality. It's losing quality. It still may only mature when you trigger with HCG or, you know, and a GnRH agonist. But I think clinically, we are gearing our output measures for the quality of a cycle and hopefully the quality of an egg based on driving the endocrine dimension of the follicle rather than its function as a gamete supporting device.
Yes, absolutely. And if you think about it, the estradiol which we measure in blood is really a measure of the follicle.
Yeah.
There is this is what yeah, it's a very important point which many people don't understand, that when they get a chromosomally matured egg, and this goes back to your presentation which you made 2 days ago, this polar body is a very early sign of egg competence.
Yes.
And it misleads people when they get these mature eggs, and you have a lot of follicles, a lot of matured eggs, and then they're surprised why embryo quality is so bad. But if you look at the stimulation, you can see why. You can see why. The more eggs, the earlier you have to take them out. And this is, by the way, explains this very strange paradox why very young patients have so many chromosomally abnormal embryos. Because obviously they will have a lot of eggs. You have to take them out earlier, and you will have more eggs. But it's like, you know, out of 100 premature babies, there will be a couple are very good.
Right, right.
And I will be asking you about chromosome abnormality in a few moments.
Okay.
But I wanted to turn the discussion to clinical application.
Nabil, can I just
Yes.
one
Yes,
thing? And I apologize. Dr. Albertini had mentioned spontaneous luteinization without LH surge, and I think that there's important to show the clinical correlation to that, and that's with IVF. Is that patients are on either an agonist or GnRH agonist or the antagonist, and we'll get elevations in progesterone. I've seen well above 3 or 4 sometimes. So that premature luteinization, if you will, is not unprecedented.
Right.
We see that in progesterone. The interesting thing is that it doesn't appear to be affecting the egg, but it does have a desynchrony effect on the endometrium. We know that frozen embryo transfer should be able to correct that, but I just wanted to interject that point.
Good point.
Yeah, thank you so much. So I was going to ask you, Mark, about, do you see a potential application as far as you know, handling patients, for example, advanced maternal age that have a shortening phase, or any other way of, do you see this as an applicable clinically in some ways, assuming the facts are demonstrable?
I think that the advanced reproductive age woman who has rapid follicular development is a very difficult one to be able to stimulate. What I have done in those circumstances is actually use the older protocols that we have as the GnRH agonist to sort of slow that stimulation and allow a little bit more development of the time for the endometrium and a cohort of follicles as opposed to a lead follicle rapidly developing. So I don't know how progesterone would help in that manner, but I think it's very exciting to think that another trigger could potentially be used, and we're always looking toward another method to reduce the risk of ovarian hyperstimulation syndrome. So if there's a way that the progesterone can be done, you know, you'll also see, you know, the PCOS patient who I'm talking about the progesterone as a trigger now. A PCOS patient, when we used to give medroxyprogesterone acetate to induce a withdrawal bleed, and then they don't get a bleed in 2 weeks, and then they have a positive HCG because the progesterone was a trigger to ovulation. So I'm very piqued interest in where this goes with progesterone.
Your comments, Dimitri? You're muted. I think you're muted. Dimitri.
Michael, why would you make comment? Because I don't want to take disproportional amount of time here.
Yeah.
Sure. As Mark has suggested, I think there is the potential that the use of progesterone might be able to be associated with a reduction in the risk or severity of ovarian hyperstimulation syndrome. Again, as he has just suggested, there may be a particular value and role in individuals who have polycystic ovarian syndrome, who already have a intrinsic disruption of the hormonal milieu with elevated LH and FSH level. Folks normally think of the LH itself, but both in fact are often elevated compared to non-PCOS women. And so may very well have a role in those individuals as well.
How do you fit so you proposed using progesterone at the end of the stimulation, right? Is that what the proposal was? Like the timing of progesterone. Can you tell us a little bit about this? How that timing is critical? Why do you think it is? Yeah, Dimitri.
Okay. Well, I mean, obviously, progesterone cannot be used in all stimulated cycles, because if you use antagonist, or even if you used agonist, you probably would have difficulties to guarantee that progesterone will trigger, because you, in one case, disabled the downstream GnRH pathway, and if you use antagonist, and with agonist, maybe you drained the pituitary and there's nothing there to trigger. But because now we moved almost completely, at least most programs, I believe, ours for sure, to frozen embryo transfers. And that's where progesterone trigger can be applicable, because for frozen embryo transfer, you can use controlled natural cycle. And in this case, there is no antagonist, there is no agonist, so you have pituitary filled with LH. And in this case, what we saw, progesterone creates beautiful luteal phase, which doesn't require any supplementation with additional progesterone. It just goes up like in a natural cycle, because you have natural ovulation. It's even more upstream than a kiss-15. It's a natural trigger. And amounts of, we also think it's a physiological trigger, because the amount of progesterone you need to trigger is minusculous. Like people are asking, how can it be 0.5 nanogram per ml in circulation would trigger? It does. It just does. So if progesterone goes from a very low level, I mean, I guess the more accurate number would be not a fixed number, 0.5, because this was from experiments of Hoff. But we think, just by looking back at some of the IVF cycle, that it's more like elevation of progesterone above the baseline percentage. Like if it was, for example, 0.2, it will trigger at 0.6. So if it's 0.1, at 0.3. If it was 0.5, which is kind of high, it would be 1.5. So it's a little bit more fluid than a fixed number, obviously, because everybody is a little bit different. And now I do want to say two words about PCOS. And I don't know, I mean, I guess it's okay to say that we have a publication in press which will come out probably September, October, I'm just estimating, maybe November, I'm not sure, which has another hypothesis. It's a derivative of what we're discussing now about origin of PCOS. So we propose that that PCOS is triggered, has a trigger, and its trigger is progesterone. And so that a PCOS is a triggering event is when a woman who is very fertile, she has a lot of eggs developing, and so on the 5 or 6, because she has such a high estradiol, she will acquire progesterone receptors very early in the follicular phase. And this has been shown by other people, that by Ledenberg, by what is his name? Anyways, it was shown that you only need like 3-4 days of high level of estradiol to prime hypothalamus for progesterone trigger. And Ledenbecker, yes. And so we think that they have such a high level of estradiol from the get-go of the follicular phase that by day 5 or 6, and follicle size 3 to 11 millimeters in this range, they have LH surge on day 6. And before dominant follicle has been identified, and so they kind of get into limbo when there is no more and no more gonadotropins to continue development, growth of the follicles, and they cannot degenerate all the way back because they are too small. They don't respond to LH because they are too small, and so they get stuck in this limbo and become polycystic ovaries over time. And it's interesting that the ratio of LH to FSH in these patients is curiously at 3:1, which is unusual for a follicular phase. It's more typical for the LH to FSH level after the ovulation, which is kind of signature of progesterone, as we think that progesterone triggers ovulation. So I just wanted to give a little bit of heads up on our thinking about PCOS and progesterone.
Very good. David, do you want to comment on what we've been listening to?
Not really.
Very good. So I'll jump into the next question. So part of what you were proposing is that the impacts on chromosomal abnormality, meaning that the maturity of the oocyte will lead to certain chromosome abnormality post fertilization. Can you explain why do you think that is the case? And I will start either with Michael or with you, Dimitri.
Sure. And actually, just 2 days ago, if you're at all interested, there was a Zoom session by the I3 group. And it was on the topic of the influence of COS on cytoplasmic maturity in the human egg. Very relevant to the question you're asking. And if I can get to the heart of it, I think, we are all concerned now as we see that in human ART, there's a high level of chromosomal abnormalities, and we know that certainly if these come from failures in either meiosis 1 or 2, and we are talking about the sensitive period where the oocyte has to execute those cell cycle steps to make this happen, then of course those aberrations will be propagated, we think, through most all the cells of the zygote, right? Okay, so that a meiotic disturbance will be translated into a very penetrant genetic abnormality in the embryo. On the other hand, I think that it's very clear that most ART embryos, the vast majority of them, acquire aneuploidies, and if they're only fractionally distributed in the embryo, we of course call them mosaics to one extent or another. that the vast majority of human embryos have aneuploid cells, not as a result of meiosis. Okay? So I think it's very important to make the distinction that now we're dealing with material that if you culture it to day 5, you do a biopsy, the chances are very good. And this has been shown with young donors. It's been shown with women under 35. This is a human thing, okay? That we tend to not do very well at segregating our chromosomes after fertilization, okay? So that said, what if we come back into the ovulatory environment that we're talking about now and ask, is there a relationship, I believe this was your question, between nuclear maturation, which would predict that both meiosis 1 and meiosis 2 proceed normally, and cytoplasmic maturation? And the answer is absolutely not. And that was kind of the take-home message from the session the other day. Nuclear maturation is programmed very early in the lifespan of the oocyte. Yes, of course, we know that in advanced maternal age, oocytes from those patients will be more prone to meiotic errors. Okay, that's for sure. And as the paper from the Danish group showed in December of 2019, it's not only with advanced maternal age, but this happens in very young women too. Okay, through a different mechanism. It tends to be a different, more chromatid, a cohesion-based mechanism. So why do I say that, we are very accustomed to thinking that, oh, a bad egg means that its cytoplasm did not acquire the properties it should have in response to the LH surge. And to be honest with you, for 30 years, we've been waving our hands to try and define cytoplasmic maturation, okay? But now I think we do have a handle. We do have a handle. And what it has to do with is not so much completing meiosis, but it has everything to do with regulating polar body extrusion, mounting a block to polyspermy, appropriately transiting those early cleavages in a period of time that will allow for equal distribution of organelles. And most importantly, we now know that there are things that go on during ovulation in the cytoplasm of the egg that regulate all of the epigenetic modifications in DNA. Some of them involve demethylation patterns early after fertilization, but more importantly, at the time of compaction, certain loci are remethylated. And all of those enzymes have to be activated during maturation. So I don't want to go on because, I know we are all very interested in, where does this prevalence of chromosomal aberration come from? But I do think that from an oocyte physiology point of view, they're two separate things, at least meiotic errors versus mitotic errors. Mitotic errors, I think you could very much ascribe as Alan Handyside's group has in London, okay? We know that some of the mitotic errors are due to defects in components in the cytoplasm of the oocyte. I hope that wasn't too wordy or off base.
No, it's great. It's great. Michael or Dimitri, where does the simulation fit when it comes to a chromosomal abnormality and the likelihood of having more chromosomal abnormality? Because that what the proposal was, that the oocytes incomplete maturation will lead to more chromosomal abnormality,
Yes.
and as well as a shorter follicular phase.
Michael, do you want me to?
Sure, go ahead, Dimitri.
Okay. Well, as David elaborated very eloquently, that it's a history, not just in this presentation. It was 2 days ago. I was listening to your presentation on correlation between the history, basically, of an egg and what happens after it ovulates. Obviously, what we see after fertilization is unraveling the history of this egg. There is no such a, in my opinion, there is no separate thing such as chromosomal errors. To me, whatever happens to the egg is a manifestation of metabolic deficiencies. And chromosomal error is just one of the manifestations of metabolic deficiencies in the egg. Now, as David said 2 days ago in a webinar, that we don't have markers to measure the egg quality. We can only look at chromosomal competence, or not competence, the ability to extrude polar body, but we don't have markers to measure egg competence. And there are really no markers. I don't know any markers for egg competence. This is why my hypothesis, and I mean our hypothesis, is that maybe we can, without still knowing the markers, but try to influence the quality of the eggs by making the follicular phase longer. Because we know from epidemiology that shorter follicular phase has association with chromosomal errors, with lower fecundity, but long follicular phase does not. So we think that some females, at least some of them, may benefit from longer follicular phase during ovarian stimulation. And perhaps when a woman is on a low level of gonadotropins, what's called minimal stimulation, her stimulation is longer. And this is particularly important for older patients or advanced reproductive age, because in their case, there was a hypothesis published in a hypothesis journal, but I totally believe this is true. These patients tend to have what is called vanishing follicles, so they just disappear. And as woman gets older, like we all get older, the collagen structure in our body is changing everywhere. We see it on the face, on our skin, on hands, but it happens inside of our bodies as well. And it's conceivable that the collagens in the cortex of the ovaries is no longer able to accommodate full expansion of the follicle. So these patients tend to ovulate prematurely. When follicle pops spontaneously, progesterone goes up. This progesterone will have no impact on other eggs because there is no receptors for progesterone in the follicle, so they will be okay. But this follicle will be lost. Progesterone goes up, and if follicle was large enough, it will rupture. If not, it may just become a cyst. But in any case, it's premature. So what minimal stimulation does, it slows down the growth of the follicle and probably give eggs more time to reach competency. In our clinic, we started to use diclofenac to extend the cycle by 1 or 2 days, and this seems to improve the quality of the eggs, at least based on anecdotal evidences. So there are ways to extend follicular phase, and maybe this is the way to improve the quality of the eggs. I personally don't see any other practical approach to this problem.
Very good. Mark, you mentioned that in some patient with advanced age, maternal age, you change the protocol to allow for maybe lower stimulation dose. How does, would you agree with Dimitri that do patients with advanced maternal age benefit really from a low stimulation in your statistics, in your patient population?
Well, a couple of comments. You know, the rapid follicle patient, uh, there could be a problem with the oocyte competence, as Dr. Dozortsev was saying, but it's also the rapid follicle development is patients with advanced reproductive age. So, you know, how much of that is an age factor versus the actual rapid development. I have always worried about prescribing supraphysiologic gonadotropins to patients, and there is some evidence, obviously, to support a detrimental impact on outcome with high doses of gonadotropins. A more recent study, I think it was out of Shady Grove, did not show that there was any negative impact of high dose gonadotropins. Needless to say, we do know, to Dr. Dozortsev's point, is that in patients with severe diminished ovarian reserve, their outcome with IVF is equivalent with high dose gonadotropins or minimal stimulation / natural cycle. Either doesn't matter. So I think less is more, particularly in the advanced reproductive age patient. I don't know if less is going to slow down follicle development, because no matter how much you're going to be giving, it's still super physiologic. And if a patient is prone to rapid follicular development, the gonadotropin that's being prescribed is going to be super physiologic. So what I have done in those circumstances is use a GnRH agonist that seems to have a more suppressive effect on the ovary, and it will prolong stimulation.
Very good. Any other comments before we see the results on the poll that we just released? We have John. John, can you please take us through the poll results?
Yes, sir. So question number 1 was follicle size expansion and readiness for rupture do not necessarily mean oocyte maturation. 70% said they agree, 26% said somewhat agree, and 4% disagreed. Do you want to elaborate on that, Dr. Ross? You want me to just read?
No, I think you can just go through the questions.
Yes, sir.
Yeah.
Yes, sir. So question number 2, oocyte incomplete maturation can lead to chromosomal abnormality in the embryos. 57% agree, 35% somewhat agree, and 9% disagree. Third question, shorter follicular phase can lead to oocyte incomplete maturation and subsequent chromosomal abnormalities in the embryos. 48% agree, 39% somewhat agree, 13% disagree. And question 4, E2 does not directly impact LH surge. 17% agree, 57% somewhat agree, and 26% disagree. And the final question is question 5, and that was progesterone has a role as a physiological trigger for ovulation. 61% agree, 30% somewhat agree, and 9% disagree.
Thank you so much.
You're
I think this is pretty good. It's really the webinar. I think that most people who have voted here somehow agree with the hypothesis in some ways, right? Yeah, except I think the role of E2, there is a little bit of how does E2 impact the LH surge? But I would like to get your feedback on the poll, each one. I will start with you, Mark.
Well, I think that the audience is obviously compelled by the paper that Dr. Diamond and Dr. Dozortsev have published. There's evidence to support progesterone's role, but I think we do need to know more. I think you are going to need estradiol, progesterone, and LH. You know, we know that the primed follicle to allow progesterone to trigger has had LH secretion in low doses of estradiol. So estradiol in low doses will cause synthesis of LH rather, and then in higher doses is supportive of the secretion. So I think all 3 factors are involved. I think you need estradiol, progesterone, and LH search. But the audience obviously is showing that, that this is exciting breakthrough in understanding progesterone, but we obviously need to learn more.
Yeah, thank you so much. David?
Yeah, no, I think the results do show that Dimitri and Michael have persuaded these people to think differently, and this is a good thing in this day and age, because I think an undertone of this conversation and many that are going on right now, again, is that not many of the eggs we retrieve make babies. And so it's time to, look very carefully at, alternatives to traditional stim, as we've, heard from Mark and others. The GnRH agonists may be or minimal stim, may be gentler ways to go, and start to change our philosophy from, more is not necessarily better here.
Yeah.
Again, we're going to need those biomarkers at some point to understand what is a high quality egg or a high quality embryo. But the poll, I think, is informative. People are open-minded. That's what I see coming about.
Fantastic. Dimitri and Michael, any comments?
I would just say it's exciting to me that folks are open to the concept, the hypothesis that we have proposed. And personally, I look forward to further testing and examining of this hypothesis and to better understand the physiology, and then ultimately to see if it can be used to improve outcomes of oocyte quality and pregnancies and take-home babies.
Dimitri?
Well, I'm surprised, surprised that so many people actually were persuaded by our arguments. But I'm positively surprised. I'm happy that a lot of people just begin to think about it and receptive to this idea. I'm very excited
Very
to see
good.
that.
I have a question for you guys. So if you have to design a study to measure the impact of progesterone as a trigger, what that research plan would look like?
Um,
Are you planning to do a study, a
yeah.
clinical study on this?
Yeah, we're thinking about it. Well, I mean, as I said, the progesterone without any questions can induce ovulation. This was not our discovery. We just shown that it can be very, very low dose, and I explained in the beginning, we broke down some of the barriers which were preventing looking at progesterone as a physiological trigger of ovulation. So we are mostly excited about using progesterone for a trigger in the frozen cycles to get away from any additional luteal phase support. This would be a lot of saving of pain and money for patients. And we think that natural trigger, we expect it to improve implantation rates. This is where we want to focus our efforts. And not directly on control ovarian stimulation and using progesterone as a trigger, because as I explained, it will in many cases just not work.
And probably focusing on advanced maternal age, because that's where the challenge is.
No, for those patients, I think that it wouldn't be a question of a trigger, because they still have to have control ovarian stimulation, where progesterone doesn't. I don't see it playing any significant role. But I do see it just understanding of this relationship between the shorter follicular phase and the progesterone as a trigger. I see us trying to expand to make it longer follicular phase by a couple of days using chemicals, or I mean, just not chemicals, I guess, over-the-counter medications, which can reduce inflammation in the follicle. And by doing this, based on our anecdotal experience, prevents premature rupture of the follicle, prevents progesterone rise, and extends the cycle for those a couple of days, which we need to give to the egg to complete its maturation.
Very good.
You know, I was going to mention, if you don't mind,
Of course.
that the article talked about the knockout studies in animals, and I was wondering if you all would consider using the unique model of the hypogonadotropic hypogonad patient who is lacking GnRH, of course, and give them low dose of progesterone just to see endogenously what LH response is going to be. You know, there's no follicle developing. They're just basically, their pituitary has the FSH and LH ready, but it's just not getting the stimulation from GnRH. It might be interesting to see if you get just low doses of progesterone, what kind of an endogenous effect that would have.
Michael, what do you think? I prefer if you reply.
And just put me on the paper, though. That's all.
This is no problem.
Yeah, that is an interesting thought. And just look at the endocrine. I think what you're suggesting is looking at the endocrinology of what happens in response to giving progesterone to these individuals,
Irrespective of a follicle.
and that would be something interesting to look at.
I agree. I agree.
Thank you so much. Well, we are coming close to the end of the webinar. We have one more poll results. We asked the attendees if they liked the webinar, they enjoyed it, and 100% said yes, that's refreshing. And if they wanted to see a webinar like this, also 100% said yes. That's the highest number we've had in our webinar history. With this, I would give you guys a minute to introduce your practice or your interest, so that you are very known, but I would like to give you that minutes to introduce yourself and your practice. And I'll start with you, Mark.
Oh, thank you, Nabil. That's very kind. And I, once again, greatly appreciate the opportunity to be with such esteemed panelists. This was very educational for me, and I thank you for the invitation. I'm a reproductive endocrinology and infertility specialist, board certified in Orlando, Florida. And I'm also a professor at University of Central Florida. I teach the OB/GYN residents and the medical students. My practice is fertility care, the IVF Center. And my passion, of course, is my patients and an evidence-based approach. And we have nice research papers with the residents and the medical students, and education and academic medicine is most important to me.
Excellent. David?
Yes, thank you again, Nabil. I enjoyed this, and I enjoyed interacting with the other participants. I wear two hats right now. One is that I continue to be the editor of JART, and it's grown over the years that I've been doing it, so that keeps me busy. And I'm now working at the Bedford Research Foundation after a pretty long career in academia. I'm working on activating human oocytes to make stem cells from parthenogenetic blastocysts. So that's been an exciting project, and it's absolutely related to what we've been talking about. And in fact, we have found that progesterone is a good way to go with this material.
Very good. Thank you so much. Michael?
Sure. As mentioned earlier, I am a reproductive endocrinologist. I'm at what is now called Augusta University. Our institution has gone through a whole series of name changes, and is probably best known around the country as Medical College of Georgia, which is now one of our 10 colleges within within Augusta University. We have a reproductive endocrine practice, which is headed up by Larry Lehman, with a big interest on reproductive genetics within that. And I am very much involved at the university with research administration in my role as the Senior Vice President for Research.
Thank you so much. Dimitri? I think you're muted. Dimitri, I think you are muted.
So, well, I'm a reproductive embryologist at the Advanced Fertility Center of Texas in Houston, and also president of American College of Embryology, which we founded about 10 years ago with Peter Nagy and Ashok Agarwal. So we will, by the way, continue this subject through the college webinars in the near future. So you can sign up to the newsletter of the college at mcall.org, and you will receive notification when we start the lectures. So yeah, I am very honored to be on a panel with very esteemed colleagues, and looking forward to maybe one more webinars. Thank you very much, Nabil. You know, I think you have an awesome format and very strong organizational skills.
Thank you so much.
To
Thank you.
this.
Thank you.
Thank you.
Very good. So we are coming to the end of the webinar. Next week on Wednesday, September 16, we will have a webinar on minimal stimulation. So I would like to invite all of you to attend. With this, we are coming to the end. I would like to present my appreciation and my gratitude to each one of you for your expertise and your contribution. Thank you so much, and I will see you next week. Thank you.
Thank you,
Thank you,
Nabil.
Nabil.
Thank you, everybody.
Bye-bye.
Thank you. Bye-bye.
Bye.
Bye.